Hello children of a lesser joint and welcome to today's video. Today I'm going to talk about your TM joints and splint therapy. You may know them as appliances or orthotics, or you may know them as being attached to specific group philosophies like LVI or centric relation or neuromuscular or GNM. If you recall, the last video I presented was a video where I had a diagnostic failure. I was actually able to make some progress on behalf of a patient and getting them out of pain with a splint. However, what I was unable to diagnose at the time many years ago was the fact that this patient had a sexually transmitted disease, chlamydia trachomatis. And thankfully for that patient, he went to his physician, and the physician was able to put together the pieces of the story that he hadn't told me. Thankfully, he was placed on an antibiotic and had a complete recovery. This is an imaging study of the second patient whose arthroscopy I showed you in the real cause of disc displacement. So if you need to go back and refresh your memory, or you haven't viewed it before, you can take a look at this. And here's a patient that has a lot of fibrous tissue. You can see that on the arthroscopy as well in that portion of the video. But also they have a very large joint effusion, both in front of the joint and behind the joint. Notice that they have substantial degenerative changes on the top of the condyle over here, and these focal areas which are likely to be osteonecrotic changes. So this joint is in some way being deprived of blood within the condyle. Now this patient was unable to move in any direction without pain. I couldn't load her joints, that's how we say it in dentistry, without pain in any direction. So here, I'm thinking to myself, if I was to move that joint forward, as is done with an approach used similar to LVI or neuromuscular or GNM, I'm not going to be able to provide satisfactory relief for that patient. Certainly, if I have her bite straight down, she's got these bone marrow abnormalities and she can't tolerate load there either. And then I have to be concerned about what happens beyond that in the area behind the joint where there's this additional effusion, okay, which is fluid in the joint. So this is a case that I chose to refer for an arthroscopic procedure, and it's now almost 7 years, and this patient is pain-free. So we can see that unless you have images that give you information about the clinical correlation that's substantiated by the imaging study showing abnormalities, I wouldn't want to put a patient in an appliance that had the features that this patient has. What I know about this patient is that she has Hashimoto's disease, and I helped her discover antiphospholipid syndrome, an autoimmune disease. So that's where we're at with this patient. And as I continue along with the same patient, I'm just delineating the areas that I see on the MRI where the disc is displaced and out in front, and I can see my little osteonecrotic changes comparing different imaging sequences. And I'm going to move along now. Now, this is the first patient that I showed you. This is the first arthroscopic procedure you see on that video called The Real Cause for Disc Displacement. This patient had a combination of both Hashimoto's disease and Lyme disease. And you can see that this patient has a huge effusion in the joint area behind the joint. She also has some bone marrow lesions, which I'm going to show you on part of her other imaging study. But again, this patient is unable to accept load anywhere I would maneuver her to. So that's a problem. And here you can see I did this as a fat suppression study with contrast, and you can see how the areas around the joint, this is on the lateral pole, and this all the way down here is the medial pole. So I'm going from outside to inside of the joint, but look how bright she is in the areas surrounding the joint, as well as inside of the condyle. Here's the disc displaced out over here. So once I can't move a patient into a comfortable position, and I do this by helping them move into different directions while their jaw is open, the game is over. If I cannot load the joints, there's no splint therapy in my practice that's offered. Another arthroscopic procedure. She's now 6 years out and doing wonderfully well. She was placed on antibiotics for the Lyme disease, and again, she seems to be doing terrific. So here are two cases where alternatives to what you would consider to be conservative therapy were offered, and at a far reduced price overall for the disease form that they had. So that's a benefit to the patient. Before I would try an appliance and dedicate that patient to potential changes in the joint, and I'm going to show you a case just where that happened, I always take the most conservative approach, and I think arthroscopy among the surgical procedures is very conservative, and I've had some great success with that over the years. So I'm in departure from what's being offered in what people consider to be conservative modalities. And you can see just the arrows pointing to the effusions throughout. Now, I've showed this slide before in many different forms, and it talks about EMG, which is muscle activity, in relation to changes in vertical dimension. And we find that bite forces and joint loads increase when we increase the vertical dimension. So here's a case that I started in 2007. This is a friend of the family. This is a young man. He has Hashimoto's disease again, along with idiopathic thrombocytopenia purpura. So he has reduced amount of platelets. That's what that means. And from the time that I made him the appliance in 2007, you can see that when I look at this head on, it looks okay, but when I take a look underneath, you can see that there's a gap here. There's a space, and I knew right away when he walked in 2009 that I was in trouble. I have the models from 2007, and you can see that his upper and lower teeth are meeting, and there's a substantial amount of contact in the back teeth as well. Well, take a look at what happens when I take the appliance out. Now, these were the original contacts, so I know I had solid contacts of all his teeth at the time that the appliance was fabricated in 2007. But here you can see, in 2009, look at the substantial open bite that develops. So I now take the appliance away from him, and I am going to hold my ground, and I'm not going to do anything. So this is approximately 2 months after I had seen him, which was around Thanksgiving time, and already he's starting to show some improvement. Here he is 2 months after that January visit, so now it's close to 4 months later, and notice how his bite is starting to close. Now, I think it's important for us to discuss here the number of abnormalities you're going to find in painful joints, because what we do is we make it all about the disc. I call it chasing the disc in TMD disorders. And we find that there are lots of patients with painful joints who not only have joint effusions and disc displacement, but have other disorders as well. They have osteonecrosis, they have erosive changes, They have bone marrow lesions or bone marrow abnormalities. They form osteophytes and sclerosis. I also showed you on the arthroscopy that there was a substantial amount of synovitis, and that's exactly what Dr. Israel, who does my arthroscopies, has found. He's produced an awful lot of articles between 1991 and 2010. So I think it's important for you to recognize that there are changes here. And also in a study by Larheim, they found that people with painful joints who ended up going for surgery and had core biopsies done had osteonecrosis, 18% of them. So when we take a look at the literature, it's not just one issue that's at rest here, and that would be, of course, the disc displacement. And it's not so easy to make a decision as to which patients are going to have the adverse response to splint therapy. And I think that's an important underlying theme, because the last thing I want to do is to make that patient worse. And had I not gotten that patient back into a reasonable position, I didn't do anything actually, he went back into a reasonable position, that patient could have been condemned to an orthognathic procedure and or surgical procedure, which would have been an open joint procedure. As it is, that patient also had arthroscopy, and within the time frame from 2011 to 2017 currently, he is doing amazingly well. Now, this happens to be a friend of the family, so I keep in touch with them all the time. The last picture that you saw was actually taken at my house where the family came over for dessert, and I sat him down in my kitchen and took a quick picture. So that's where that comes from. And here's Dr. Israel's bibliography, just to keep me honest and show you that I've done some research in the literature on his particular articles. So when we take a look at different types of images, please be aware that you are not all the same. You are not comparing apples to apples. You are a unique individual, and the needs of your particular care need to be customized for you. When you're online and you're in these different group sites and you're trying to obtain information from other patients who've experienced similarities in their pain profiles, you're not comparing the apples to apples. You're just experiencing their problems in their lives through them. And it may have absolutely no value to you at all. So just be aware of that. Notice how the patients have different diseases. While there was commonality with the Hashimoto's, the other attending comorbid diseases were different. One had Lyme, one had idiopathic thrombocytopenia purpura, called ITP. The other had antiphospholipid syndrome. And these weren't even among the patients that I have extensive studies on. I can't even imagine beyond this what could be diagnosed had they allowed me to go further. Interesting question. And so here in Tanaka's article, which was the first article that I showed you with patients that had concurrent manifestations of joint abnormalities, he also finds bone abnormalities. So this is the 2002 article by Tanaka. That was the first article I showed you. When I take a look at different imaging studies in a patient like this who has inflammation right around the cap or top of the joint, I can't load that joint. No centric relation splint for this one, I assure you of that. Nor can I move this joint forward without the patient having pain. So the presentation will often dictate what the doctor may be able to do. If they're telling you they're just going to hook you up to some electrodiagnostic modality and see if they can move your jaw joint, you could be in trouble if you don't have an MRI, because this is what you need to have done in order to ascertain exactly the inflammatory processes going on in your particular case. In this patient, she presented with osteonecrosis. Dark on T1, dark on T2, characteristic crescent shape, abnormality with what's called a frog leg. No treatment was rendered. It resolved by itself. This patient had a coagulopathy as well as rheumatoid arthritis, taken over by her rheumatologist and a hematologist. No dental treatment was necessary. Her bite remained stable. So going back to the patient who developed the anterior open bite, look how terrific in 2010. We're looking still a little anterior open bite, but it's satisfactory. Patient's doing really well. And here are the changes on November 24th. That's when he was over my house for dessert on Thanksgiving, and I got these pictures. Actually had to give him a toothbrush, a fresh toothbrush, to go to my bathroom. So here you can see, without any treatment at all, took the appliance away from him, we're able to get his bite close to normal. There's the side views. So there you see it. January of 2010 to November of 2011. Now, here's the part that I'm most interested that you see, because when you take a look at the imaging studies from 2007 and then compare it to his increase in pain, which prompted him to come back in 2009, you can see that there are apparent differences. So I picked out a couple of images to show you. Number one, you can see that his disc is in a reasonably good position in 2007. Notice over here, he's got a little divot. Not much going on. But here in 2007, when we take a look at the lateral pole, you can see there are already some angular changes, and here is that erosive lesion that's going on. So this is an early case. There's the disc out in front. It's displaced off of the lateral pole, the outside of the condyle. When you take a look at 2009, you can see that there's interspersed material. The disc is displaced at this point even further over here. Bright on T1, bright on T2. That's called the fat replacement process. And here's the part that I want you to see. In 2007, I want you to take a look at the shape of this condyle, because you can see it's got a normal tiny little bend. But notice how it starts to be shaped like a hockey stick at 2009. And that probably comes from the force that was generated by wearing the splint. And what he had done is he was in school, he wanted to live a normal life, his joints started to become more painful. I had him using the splint only at night, and he started to put it in full time in order to see if he could make an improvement in his pain without coming to me or calling me. And so this is the result of it. So I think we're going to end at this point today, and I will pick up again next visit. This is a wonderful time for those of you who are new to the group to be coming in as new members. I'm going to be going very shortly, within the next 2 lectures, to what I call 4SD, 4-sector diagnosis. Before you do any treatment as a dentist, or you accept any treatment as a patient, you need to know what can be done for you diagnostically. And so I am going to put an enormous amount of time into diagnosis, because there are things going on you have never heard of. And I'm extracting that information from patients that I get to do extensive blood diagnosis on and imaging studies. So, I hope you'll join me for the next episode when I'll be rocking it out with Jaw Talk.